So thank you, Uli, and thanks everyone for coming. And I had the pleasure of attending one of the prior sessions. I was really inspired by everything everyone is doing, and so very privileged and honored to be here tonight. So as he mentioned, I'm cardiology assistant professor at Stanford. I've been on faculty for about 8 years, and about 3 years ago, founded the SoPE clinic. SoPE is a South Asian term that many of you may recognize as meaning friend or companion. And really the acronym is the Stanford South Asian Translational Heart Initiative. So we're a cardiology clinic with 5 cardiologists and a multidisciplinary team that reduces risk in South Asians. What we learned very quickly was that our patients were struggling to understand how high risk they actually were. And when they walked into our door, many of them were coming from primary care physicians, many of them were coming from other cardiologists. And the average age of the patient in our clinic, because of the problem in South Asians, they're very young. So for a cardiology clinic, the average age in our clinic is 42. On average, across the country, the cardiology patient age is averaging around 58. So we have a very young population to have such high cardiovascular risk. About 70% of our patients have hypertension or pre-hypertension. 65% of our patients have pre-diabetes and insulin resistance. And virtually 80% of our patients have some form of dyslipidemia. So we have a huge amount of risk in this population. And when you went to the guidelines and said, what do these patients actually need? They weren't on it. Most of them were not on lipid-lowering medications, blood pressure medications, or diabetes or pre-diabetes treatments, despite the guidelines suggesting that they should be on them. And that was kind of the inspiration behind HealthPals, which was, how can we create a product that would package specialty insights and deliver them at the point of care to primary care physicians and cardiologists, and personalize that information for the patient they were seeing at that moment. And so that's something that I was lucky enough to meet my co-founder, Sushant Shankar, who couldn't be here tonight, but he is a data scientist with a strong background in healthcare and even ad tech, who has used machine learning and algorithms on a variety of data to apply to healthcare. And we founded HealthPals in 2015. So we're empowering a value-based renewal, which I'll speak about in a moment. But you ask, why does it matter whether guidelines are actually followed or not? And so the data that we have available to us is stemming originally from a RAND study, which is a research group that published about 10 years ago that the adherence to guidelines across all specialties in medicine are really abysmal. It's about 50 to 55% across the board, meaning about half the time physicians are not actually following the guideline-driven recommendations for their patients. And you may say, well, the guidelines may not apply to my patient, or there are special exceptions to all of these cases, but on the whole, this is impacting mortality. And so the RAND study was followed by a UCLA study that showed that if you follow the guidelines at the current level, you'll have a certain amount of deaths and medical errors associated with that. However, if you were to improve your guideline adherence, you would have fewer deaths and fewer medical errors. So there is an impetus upon us to be more adherent to the guidelines. Now, the RAND study pointed out 2 reasons why this was the case. Why were physicians not following the guidelines? The first was that they didn't actually know that the guidelines applied to that patient they were seeing at that moment. They actually didn't know, partly because they had a fundamental gap in their knowledge, but mostly because the guidelines had changed within the last few years. Now, the American Heart Association changed 57 of their 105 guideline documents in 2015 alone. So that's over half of the documents, and who can raise their hand and tell me how many changes those were and what those were? And I have no idea. I'm a cardiologist, and I only know about 3 of them. So they apply, but you have to know when they apply, and how do you keep on top of that? Over 1 million publications in medicine are published a year. So how are you going to stay on top of the newest literature? So this is a challenge. This is information overload. And we sought with HealthPals to do something in preventive medicine that could potentially manage this, this problem. So what is Clint? So HealthPals is a digital health solution. It's a software solution that is sold essentially as a platform as a service or software as a service to providers, to payers, to employers, to understand the risk of their patients, their patient populations, and their opportunities for intervention that are guideline and evidence-based driven. So essentially, HealthPals extracts data from the EMR, populates those fields for that patient, and shows in one screen the overall 10-year risk of heart attack or stroke for that patient. And in addition to that, shows the individual contributions of each one of those patients' risk factors to their overall risk. As a result, you could model the impact of not having that risk factor. Now, in addition to that information, this data also feeds into the guidelines. And so we have a partnership with the American Heart Association, with the American College of Cardiology, and soon several other knowledge source societies to actually codify their guidelines and bring them in an immediate package at the point of care that shows physicians and providers of any sort what treatments are actually indicated for their patients at that moment and specific for the patient they're seeing in the room at the moment. Now you can imagine there are lots of ways to depict this, but we'll start with the point of care, and I don't want to take up too much time, but you'll get the picture. But basically, this patient has an 8.7% 10-year risk. Based off QRIS-2, you could toggle this for the Framingham score, ASCVD, whatever score you would like. And this is based off of this 49-year-old white female and her actual EMR data. And she meets criteria for several different interventions, a high-intensity statin, the DASH diet, diagnostic workup of her hypertension, and she should get a 3-month follow-up. Now, these are the knowledge sources that actually supplied those guidelines, ACC, AHA, JNC7, and AHA up here. These are the reasonings. This was the grade of the evidence. This was the impact on her QRIS-2 score if she were to not have that risk factor. And so you can then drop down to see the more detail on the action, the reasoning, and the risk contribution. And this is all in one screen. The other factor that is really relevant for value-based renewal is that if you look at the MIPS and macro criteria that all providers are now beholden to report upon every year for Medicare reimbursement, they are essentially driven by the guidelines. So if you go through the chart that Medicare CMS has issued, and you look at the knowledge source that issued that MIPS criteria, it's often AHA, or it's ASCO for oncology, or it's ATS for pulmonology. So we know that they have not just pulled these out of thin air. So there is a quality and therefore a financial impact to following the guidelines. And so this solution actually shows you in one screen an actionable set of guideline-driven and quality metric-driven recommendations. So you can then, in front of your patient, also emphasize the impact of doing the intervention that we're recommending and the relative impact it'll have on their overall risk. So that's what HealthPals is doing. We also have, by starting at the point of care with guideline-driven recommendations, we've now moved up to the population level and can present some very powerful visualizations of impact of interventions at a population level to identify the highest risk patients, the most impactful interventions, and that is leading now to machine learning applications in terms of optimizing outcomes. So that's what we're doing. Thank you. Yeah.
Question, how's your software different from a regular calculator that is provided on American College of Cardiology website?
So great question. So the question was, how is our software different than a regular calculator, like for instance, the American College of Cardiology calculator? It is the number, the 8.7% or whatever the ASCVD score would be, is identical. The data sets are public and able to be shown. What is not shown on any of those calculators is the rest of that donut that you see there, the relative impact of each one of those risk factors on their overall score. And that is dynamic because of the modeling that is required to produce that. So that risk depiction is, at its core, the same number, but there's a lot more information contained in what we provide. Yeah.
So when you're in clinic, the screen space is limited and time is limited. Is there any intention of, instead of having a full web browser view, to actually make it smaller so it doesn't compete with the EHRs too much and is used more?
It's a great question. So the question, I'll restate it, was screen space and workflow, I think is what you're getting to as well. You don't want to compete with the actual EHR in terms of attention, but you still want to get the information there. There's two ways that we approach that. So we do make applications for the physician, for administrators, for clinic coordinators, that they can view this information at a per patient or population level. That could be a web-based view. However, we also have a cloud-based API service that you could actually bring this information into your own visualization, into your EMR of choice. So.
Hi, I'm Sridhar, Dr. Dash. A lot of us here are entrepreneurs and investors. Could you speak a little bit about how much it costs you to build the software, what HealthPals, valuation is, and are you trying to raise money right now? I mean,
yeah,
we're kind of interested in investing.
Yeah, so thank you for the question. So our current stage of the company is that we are VC backed. We raised a Series Seed round late last year. So we are looking to raise a likely Series A at the end of this year. And as people have often told me, always better to raise money when you don't really need it. If you can do that beforehand, that's a wise move. So we are definitely interested in talking to people who would like to be part of this effort. It took us a long time, and some of our phenomenal engineering team is sitting over there building the interface, which a lot of our physicians have loved and helped us improve with iteration. Building the back end and the engine has been challenging, and we deal with new challenges all the time. So it's not cheap, but we've had some very supportive investors. Our first investor in our company was Yogan Dalal. Some of you may know him. He used to head up the Mayfield Fund, but now is doing a lot in the healthcare space. And he had a vision match with us early on, and we were fortunate enough to connect with him, and that helped us jumpstart our effort. But it initially was friends and family, and that's always, it was a scrappy effort. It still is a scrappy effort, trying to keep costs down. And we're located right up here in Millbrae right now in a small office space, but it's working out for us. But it's been fun, but the healthcare industry, as you all know, is a little bit of a tough nut to crack in terms of selling to providers and provider systems. So we've had to learn from their feedback to us as to what's going to move the needle with them. So, yeah.
One more question though. Now about more like a technical part of it. Are you working with some major EMR providers like Epic, for example, or like Cerner?
Mm-hmm.
And do you feel there's a pushback from them to kind of integrate your software, for example, if you work with them?
Yeah, so the question was, are we working with major EMR companies, and are they resistant to working with us? So we integrate with major EMR systems. We actually, the technical side, as many of you may already know, of integration is less challenging than the political side of integration. And so solving that maze is really a challenge, and unfortunately with something like Epic, which is not a cloud-based EMR anytime soon, you have to do it at every single installation and whoever is the IT group. However, Athena Health, which is a cloud-based EMR, is a one-time integration, and that worked out quite well with our efforts there. So the cloud-based EMRs are certainly more amenable, and they actually want this type of integration. I think Epic is the big dog in the room, and they often want to just build it themselves. So we've been very careful with Epic, but they're open, at least, for instance, Stanford is going to be using our product in their primary care clinics this fall. And we have some other large systems that are also looking to work with us, and they are Epic installations. So it's site by site, and it's a political battle.
Last question.
Yes, sir. Have you done the forecasting on, not just the clinical side, but the cost implications of reduction of utilization, etc.?
Mhm.
Does it have like a visualization too? If you're running any kind of, contract-based or risk-based contracts?
It's a fantastic question. So are we visualizing cost and based off risk-based contracts? So we're building those right now. So getting access to claims data is often challenging for the exact same patients you have EMR data for, but we've seen interest on the part of our clinical deployment sites in giving us that information because we can build those models. It's important to show the impact on reimbursement, on billables and deliverables, and we feel like, I didn't even talk about how we close the loop with patients in this system, but you can, and we have our own patient app, but we could work with any other patient app to close the loop and start to take advantage of some of the reduction in readmission rates, those types of things. So yeah, we are building those things, but as of yet aren't fully operational with those.